Yes. All right. Good afternoon, everyone. Welcome to the Women's Health Workshop presented by the Healthy Southwest in coordination with the University of Chicago and the Resurrection Project. My name is Lilia Guevara. Please note that all questions can be put in the Q&A function located at the bottom of your screen. And for those using your smartphone, you can find it by tapping the three dots on the menu option. All questions will be answered by Dr. Stolberg at the end of the session. Recording of this presentation will be available on the Southwest Organizing Project YouTube channel. And thanks again for joining us today. I am Lilia Guevara. I am the coordinator of the Healthy Chicago Equity Zone and McKinley Park Community Program with the Resurrection Project. Our mission is to build relationships and challenge people to act on their faith and values to create healthier communities. We believe that social change starts at the community level. When individuals feel safe and secure, they are more likely to invest in their community, making it a better place for all. We support our community with different programs like financial wellness, affordable housing, immigration services, leadership development and civic engagement, Hope Family Counseling Services, ELLAS, supporting breast cancer survivors, Chicago Community Health Response Corps, supporting meddling access to health resources, and Healthy Chicago Equity Zone, supporting the community with initiatives and strategies to confront the social and environmental factors that contribute to health. We do this with passion, character, and commitment. And with the same passion and commitment, Dr. Deborah Stolberg is here. So she is our presenter today. Welcome, Doctor.
Hi, thank
So
you.
let me introduce Dr. Deborah Stolberg. She's a professor at Chair of Family Medicine at the University of Chicago. And she joined the university faculty in 2007 with a primary appointment in family medicine and secondary appointments in obstetrics and gynecology section of family planning and contraceptive research, and the McLean Center for Clinical Medical Ethics. Dr. Stolberg graduated from Harvard Medical School and completed her family medicine residency at West Suburban Hospital in Oak Park, Illinois. She received a Master's of Arts in Public Policy from the University of Chicago, where she also completes fellowship training in primary care research and clinical medical ethics. Her research focuses on reproductive health service delivery in the United States. This includes studies on incorporating reproductive health in primary care, addressing racial and socioeconomic disparities in pregnancy outcomes, and understanding how religious healthcare institutions affect care delivery. She directs the Reproductive Health Outcomes and Disparities Research Group and co-directs the Research Consortium on Religious Healthcare Institutions. Dr. Stolberg provides patient care at the Federally Quality Health Center on Chicago's South Side. Welcome, Dr. Stolberg.
Thank you. Thank you very much. And thank you to those attending. We will definitely make sure to leave time for questions. And I'm going to go through a number of topics. So we have a lot of material to cover. And then at the end, we'll suggest some resources that you can turn to for more information if you want to look things up on your own. So let me start sharing my screen. Okay. You guys can see this, right? Okay, wonderful. So give me a quick second. Yeah, so here's the topics we're going to cover tonight. We're going to talk about cervical cancer, including pap smears and HPV, which is the human papillomavirus, and red flags to look out for. We're going to cover breast health, mammograms, and red flags to look out for when it comes to breast health, sexual health, pre-pregnancy and pregnancy health, fertility, menopause, what to expect, and some general tips and advice. And then, as I mentioned, we'll share a few resources. I do want to comment that this talk is for everybody. Even though the topic is called Women's Health, we think it can be helpful for all people. And We also recognize that not everybody who has the body parts that we're talking about tonight, like breast, cervix, and uterus, identifies as a girl or woman. So we hope this is relevant to you, however you identify. So starting with cervical cancer. Cervical cancer is a highly preventable form of cancer. One of the most important causes of this cancer is the human papillomavirus, or HPV, and we actually have a vaccine against that significantly reduces your lifetime likelihood of developing cervical cancer. It's best if people get this vaccine at ages 9 to 10, but you can get catch-up vaccines if you don't receive all the vaccines by age 10. The other main form of preventing cervical cancer is to have regular screening with a Pap test and or an HPV test, and these should start at age 21. A Pap test, which we also sometimes call a Pap smear, looks at cells from the cervix to see if there is cancer or precancer. And the HPV test looks for high-risk forms of this virus, which can actually cause the cancer. The good news about these tests is that because they are highly effective, we don't need to do them as frequently as we used to. Many of us grew up thinking you should go in for a Pap test every year, and that turned out to really be over testing. We were probably picking up things that had no importance and doing unnecessary follow-up tests like biopsies. So the guidelines now say every 3 to 5 years, depending on your specific situation. And it is important to keep in mind that not every pelvic exam is a Pap test. So you may go in and see your healthcare provider and they recommend a pelvic exam, or they do some tests that involve inserting a speculum in the vagina, similar to when you have a Pap test, but it might not actually be testing for cervical cancer. The actual test for cervical cancer is the Pap test. So what are some other reasons that you might have a pelvic exam? If you are having abnormal discharge, itching or irritation around the genitals, pelvic pain, or bleeding that seems abnormal to you. Those are reasons to go in, and that you may be recommended to have a pelvic exam or have tests done. And it's important to ask, what is this a Pap test? Another reason is a concern for sexually transmitted infection. Now, you may not need to have a pelvic exam for this. These can sometimes be very effectively done from a urine sample. But I mention these because even though the Pap itself is every 3 to 5 years, you should still go in if you're having any of these symptoms. If you have concerns about a sexually transmitted infection, like if you have a new partner and had unprotected contact, and it's never wrong to go in and ask what your healthcare provider thinks might be going on, or to share your concerns. Going back to cervical cancer, though, I wanted to show what the cervix is. It's the lower part of the uterus. And so when a healthcare provider puts a speculum in the vagina and looks at the back of the vagina, they can see the face of the cervix, which is the opening of the uterus. And the reason that we do these Pap tests is because if caught early, cervical cancer is highly treatable with very good survival rates. If you do have a Pap test and you're told that it is abnormal, that does not mean you have cancer, but you probably will need further testing, possibly a colposcopy or a biopsy, to see what the cause of those abnormal cells was. Another option may be that they will recommend that you come back in 6 months or a year, rather than waiting those 3 to 5 years if everything was normal. The main red flag for cervical cancer to be on the lookout for is abnormal bleeding. This could be if you have already been through menopause and you haven't had bleeding for over a year, and then suddenly you start bleeding again. It could be if normally your periods come very regularly every month, and now suddenly you're having spotting or bleeding in between your periods, or just anything that seems abnormal to you. Okay, moving on. And Lilia, can I ask, would you prefer for me to pause and answer the questions as they come up, or to wait till the end?
We can just wait to the end, please. Thank you.
Okay, thank you. Okay. Now we'll move on to breast health. So in general, breast development begins between the ages of 8 and 13, and it progresses through 5 stages. So stage 1 is pre-puberty. This is in childhood. And by stage 5, that's the adult breast. That is typically achieved by age 17 or 18, but there is a lot of individual variation. So in some cases, your breast can continue to grow into your early 20s. And it's normal for there to be unequal growth between the breasts, especially during these teen years, but even into the adult age. The main red flag that we always want to keep an eye out for is changes in your breasts, one or both breasts. The way to know if you have had changes is to have a comfort with what your breasts feel and look like at baseline. In other words, what is normal for you? Because everybody is different. Some people's breasts will feel lumpy, some will feel smooth. And so by knowing what's normal for you, you can be on the lookout for changes. And so this illustration is showing a good way to identify those changes, what we call a breast self-exam. So the first step is to look in the mirror with your hands both at your sides and then above your head, and then use the pads of your finger to feel for any changes. And those could be, and so here are some of the possible red flags, is lumps or hardened knots inside the breast or on the surface of the breast, signs of swelling, redness, or skin dimpling, like any changes in the texture of the skin, or changes in the nipple, which could include appearance, texture, or abnormal discharge coming, like fluid coming from the nipple. Even if you don't have any of these, if your breasts feel normal, it is important to do a screening test for breast cancer. And the most common screening test, the most widely used, is a mammogram. There are some circumstances where you may be recommended to have other tests, but for most people, the mammogram is the best test. And while you will hear different recommendations, and it can be a little bit confusing depending on what healthcare provider you go to, most of the medical organizations that have reviewed all the science about it recommend getting your first mammogram at the age of 40. And then you do want to make sure, starting at age 50, that you are doing them regularly. So every other year, at least, starting at age 50. Now, these recommendations may be different if you have a personal family history, so sister, mother, aunt, or even an uncle, father, grandfather who had breast cancer. Those would be important things to share with your healthcare provider, and to possibly even consider having testing of your genetic, of your genome, to see if you have one of those genes that would put you at high risk. If you are found to, then they'll counsel you about what you should do about that. But most of the time that involves either starting your screening earlier. So rather than waiting till age 40, they may recommend that you start at 35. And it may involve getting mammograms more frequently. For comfort, it can help to schedule your mammogram when you're not on your period. Okay, I'm going to move on to sexual health. And this is a very broad range of topics, but I like to say, when I think about sexual health, that sex is great until it isn't. And there are lots of ways that sex contributes to our well-being, but there are also considerations where sexual activity may not be desired, and we have to navigate communication with our partner about what we want. There may be times where we're concerned about pregnancy and not wanting to become pregnant, and so having an understanding of what methods are available to prevent pregnancy. And then also, of course, sexual contact with a partner can come with the risk of sexually transmitted infections. including HIV and others that we'll talk about in a little bit. And the best way we have, if you are going to be sexually active with a partner, is to have you and your partner both know your status, and if you have any lack of certainty, using a barrier method to prevent the spread of infection. So condoms and dental dams are the most common forms of barriers that are highly effective, not 100%, but highly effective at preventing the spread of sexually transmitted infections. Other ways that a joyful and body affirming thing like sexual activity can be turned into something that is not what we want, or not happy, or not healthful, is if we're not really in control of our decisions, or not making, not in a situation to have good judgment. And alcohol and drugs are examples of that. They can lower our inhibitions, meaning where we would normally make a judgment not to make a specific choice. They can lower our reasoning around that, and overall affect our decision making. And so that's a way to keep yourself healthy, is to really be aware of your own limits and choose carefully about using alcohol and drugs, especially when it comes to meeting new partners and things that could put you at risk. So we've talked a little bit about pregnancy prevention, so considering contraceptive methods, and we'll touch on that a little bit more as well. And then the risk of infection. So if you do have a concern because you have a new partner, or you have symptoms that are concerning, like we talked about earlier with abnormal discharge or itching or pain, you can go into your healthcare provider to get tested for sexually transmitted infections. When it comes to thinking about contraception, there are a range of options for preventing pregnancy. There are hormonal and non-hormonal types of contraception. There are long-acting and short-acting. So long-acting usually gives us, 3 to 10 years or even more of prevention of pregnancy once it's in place. Now, those long-acting ones, you can have those removed, and then you go back to being able to become pregnant. But they are, while they're in place, they are having their contraceptive effect, meaning very effective at preventing pregnancy. There are also short acting, where you take a pill every day, or you get the depot shot once every 3 months, or you use a barrier method like a condom. And then there are ways of tracking your cycle, or the partner pulling out, that are less effective, but still an option that people turn to if they are not comfortable with other methods, or if that's what they choose. And then if you are sure that you are done with childbearing and don't want to have any pregnancy in the future, then there's the permanent contraceptive method, also called tubal ligation or sterilization. And of course, for the male partner, there's vasectomy as an option as well. We talked a little bit about STDs before, so I'm just going to hone in a little bit on the most common ones. Human papillomavirus is actually the most common, and in addition to the risk of cervical cancer, it can be associated with other cancer risks, including penile cancer, throat and mouth cancer, and vulvar cancer. It also, in the form that we often call lower risk because they don't cause cancer, it also can cause genital warts, which are not cancerous growths, but they can be uncomfortable or unsightly. All of those things, those cancers and the warts, are all caused by strains of the human papillomavirus. And the real challenge with HPV is that once you get it, there is no specific treatment to fight off the infection with the virus. There is treatment to remove the abnormal cells, And if you have genital warts, you can have those removed in a number of different ways. But that's why the prevention measures we talked about, and that includes everything from vaccines to condoms to knowing your partner's status, can be really helpful when it comes to HPV prevention and really all prevention of sexually transmitted infections. The next two most common infections, STIs, are chlamydia and gonorrhea. And these are tricky because while they are very common, people may not know that they have them. So that's why there are these reporting requirements, because we want to prevent the spread. And so there can be anonymous partner notification through the public health department. But the good news about these infections is that they are both treatable with antibiotics. Once you're diagnosed, if you take the antibiotics for chlamydia, it's usually pills that you take for a week. For gonorrhea, it's usually an injection. And that does clear it out of your system. Then you just want to make sure that your partner is fully treated as well before you have any contact with that person again. Or you could get treated and then get reinfected by accident. So good news on those is highly treatable. The other thing to know about them is that if you don't find out you have it and it stays in your system, it can over time cause scarring of the fallopian tubes. And that can put you at risk in the future of things like problems with fertility, problems getting pregnant, and even having an ectopic pregnancy. So if you have any concern, go in and get tested. And chlamydia and gonorrhea usually can be very effectively tested through just giving a urine sample. So you probably won't even have to have a pelvic exam. Okay, check my time. So starting to think about pregnancy. Actually, a healthy pregnancy begins before you become pregnant. So if this is something that you're thinking about in your future, it's good to talk to your healthcare provider about it, to talk about prevention in advance of becoming pregnant. So for example, vaccines to get. And these days, there are vaccines that are on a lot of people's minds, like the COVID vaccine and the flu vaccine. And those are both highly recommended in pregnancy or in people thinking about becoming pregnant, because those infections, the COVID infection and the flu influenza, can both cause pregnancy complications to both the pregnant person and the fetus. And so getting vaccinated in advance is the best way to protect yourself and your future baby. There are also routine vaccines that many of us think about getting in childhood, like hepatitis B and measles, mumps, and rubella, that are important to have that immunity when you're pregnant. So if you're not sure if you've had those, that could be something to talk with your healthcare provider about as well. There's also vitamins that are needed to support a pregnancy, and many of these are really helpful if you have them in your body before you become pregnant. We know for sure that the vitamin folic acid, which is in the vitamin B family, helps prevent specific birth defects such as spina bifida. Folic acid is available through food. Lots of grains have it, lots of vegetables have it, but there have been studies showing that most of us don't get enough through the foods that we eat. And so if you see a vitamin labeled a prenatal vitamin or a women's vitamin, it probably has that little extra folic acid that we need either before pregnancy or really early at the beginning of pregnancy, sometimes before we even know we're pregnant. That is important. So you can take a prenatal vitamin, you can take a plain folic acid, or you can take a general women's health vitamin. Other things to think about before becoming pregnant are your mental health, your stress level, how, if you're concerned about depression, about feeling very anxious, or any mental health concerns, those would be good topics to raise with your healthcare provider prior to becoming pregnant or at any time, because we know that pregnancy can be stressful in and of itself. It's a time that it's important to have good support. Also, if you're taking any medications, and mental health is just one example, but any other medications for chronic illnesses you might have, those are important topics to talk about before becoming pregnant as well, to see if the medications are safe in pregnancy. Healthy food and physical activity is important before, during, and after pregnancy. And generally, we say during pregnancy, the same guidelines for physical activity that we all have as adults, which is to try to get at least 30 minutes a day of physical activity. Once you become pregnant, we often just want to be cautious not to start new kind of risky physical activities. I wouldn't say, go start rock climbing if you've never done that before, really just because your body balance and body mechanics can be a little bit off. And so it's good to continue the things that you're comfortable with. But if before pregnancy, you aren't in the habit of doing regular physical activity, it's a good time to start. And then the last thing I'll say about pre-pregnancy health is thinking about substances that can be especially concerning in pregnancy and even in the very early days of pregnancy. So I mentioned medications, that you want to review those with your healthcare provider. Alcohol is a big one. The small amount of alcohol that may be healthy for adult women who aren't pregnant can be harmful to the developing embryo even very early in pregnancy. And so we generally recommend avoiding alcohol during a time that you may become pregnant. Same thing with marijuana and other substances that, everything from metals that may be there in your foods to drugs and alcohol. So these are important topics, important conversations to have with your healthcare provider. Another thing, thinking about health before pregnancy, is what's the best timing for you? And we already had some conversation about ways of preventing pregnancy until you're ready. The thing that I'll add at this time is that for the health of both mom and baby, it has been found that after a prior pregnancy, after you've given birth, it's good to give your body time to recover. The recommended birth spacing in the US is to wait at least 18 months between babies. Somewhere between 18 months and about 4 to 5 years has been found to have kind of the optimal health outcomes. But definitely closely spaced births, like with becoming pregnant within 6 months after giving birth. We have really lots of studies showing that is putting the next pregnancy at risk, putting mom and baby at risk in the next pregnancy. So after giving birth is an important time, even though it can be stressful. You're taking care of a new baby. You're not necessarily thinking about yourself. After giving birth is a really important time to talk with your healthcare provider about the timing of that next pregnancy and how to time that right for you, whether that's getting on a birth control method or whatever is going to work best for you. And again, we raised a little bit before communication with your partner and thinking about how life will change during pregnancy and after pregnancy. These are good conversations to start beforehand. So when do you actually need to go in and see someone? I mentioned some conversations that I recommend having prior to pregnancy, but certainly once you have that positive pregnancy test, it's a good time to seek care. If you're planning to continue the pregnancy, you should get into prenatal care. Usually we're recommending between about 6 and 10 weeks now. But if you are unsure if you want to continue the pregnancy, you can always come in earlier to talk about it. And if you're having any concerning symptoms, so for example, bleeding, once you become pregnant, bleeding is a reason to go. It's not always a sign that something is abnormal with the pregnancy, but it's at least worth getting checked out. And same thing with pain. We know that there can be some discomfort in pregnancy, but if you're having pain that feels significant to you, out of proportion to sort of a mild cramping, that would be a time to go in. I mentioned a few slides ago that ectopic pregnancy is a complication that can happen in pregnancy. That is where rather than being inside the uterus where pregnancy normally grows, the pregnancy grows outside the uterus, usually in the fallopian tube, and it cannot be sustained, and it's actually quite can pose real risks to the pregnant woman. And so the pain from that would usually be on one side of the pelvis, a pretty strong, sharp pain, or you could have bleeding. And so those would be, reasons to go in right away, even if I know sometimes doctors say, okay, you don't need your prenatal appointment until 8 weeks or 10 weeks. But if one of these things is happening early, you should go in sooner. You should insist. Now pivoting a little bit to talk about if you want to become pregnant and it isn't happening, if you're struggling to conceive. And the first thing to know is that you are not alone. This is very common, and that there are many potential causes. It can really stem from either partner. Some people struggle to ever become pregnant. Some people have a pregnancy or two pregnancies and then have a long period of time where they're not able to become pregnant, or it seems much harder. And there are changes that can happen in the body over time where your fertility does change. And so generally we say if you've been having unprotected intercourse for over a year and you haven't become pregnant, that is a time to go in and get checked out for fertility issues. If you're over 35 and you've been having unprotected sex for 6 months or more, you don't have to wait the full year. And that's because the assisted reproductive treatments that you may be offered work better when you're closer to that 35 point, or in your late 30s or early 40s, whereas if you wait for too much longer, they're not as likely to work. So again, I'll just say if it's been a year of trying to get pregnant and you're not conceiving, a year is a good time, but if you're over 35, going in around the 6-month point makes sense. There are treatments available. Those treatments can be for couples that are facing infertility. They can also be for people that want to conceive other than by traditional intercourse of the penis and the vagina. So people that are choosing to be single parents or LGBTQ families can also access assisted reproductive treatments. As far as maintaining your fertility or sort of thinking ahead for future fertility, it's really all those things that are good for you are also good for future fertility. Some of the ones we know for sure are to avoid tobacco, to eat healthy and stay physically active. Those are ways of helping to maintain your fertility, and also to manage your stress and to try to get adequate sleep. Being in states of chronic stress can threaten your fertility. And so if you have these concerns, they're very legitimate and very appropriate to talk to your healthcare provider. Okay, moving on towards the later phase of the reproductive lifespan, we're going to talk for a little bit about menopause and what to expect. So menopause is the natural time in life when your ovaries stop producing hormones, and so your menstrual periods stop. The average age is around 50. There is a lot of variation from one person to the next, and so there's no right or wrong age. The official definition of menopause is when you haven't had your period for 12 months in a row. The thing to know is that the symptoms, both in the time period leading up to menopause, so maybe when you are still getting periods, but they're starting to become less regular, or even if they seem regular, you may be starting to have perimenopausal symptoms. And this picture here shows that really it can affect your whole body. So we often think about hot flashes, where you get flushed and red and sudden change in temperature. But it really is not just that. You can see changes in your teeth and mouth, in your hair, in your breasts. When it comes to urinating, you may notice more urgency or actual incontinence, like urine leakage. Your bones are decreasing in density, and that can lead to a higher risk of fractures. I think, we talked about the uterus, so shorter or longer periods or cycles leading up to the menopause time. And then also the vagina itself can change with the hormone changes, and people may notice itching, changing in the skin around the vagina, vaginal dryness that can be irritating. So really there are many symptoms, and it's hard to predict exactly what it's going to be for you. But it can affect your whole body because of the hormone changes. So how do we cope with this? You're going to notice a theme: sleep, exercise, healthy food choices like a plant-based diet. Processed foods and high sugar foods actually can increase the symptoms. And so this is a time of life to really try to limit those. And then when it comes to your mental health, recognize, give yourself some space. Recognize that you may be experiencing changes in your body, changes in your mood, and these can be uncomfortable. And so you want to find things that are joyful for you, stay connected with your community, and think of this as a time of life that you really want to emphasize taking good care of yourself. And it can be hard because you can have a lot of responsibilities and people relying on you, but you are important too. And in this phase of life, it's really important to remember that. Hormone replacement is an option. So the main hormone that our bodies are reducing during menopause is estrogen. And so you can get estrogen in a number of different forms for a short period or for a longer period. It just has to be a really individualized conversation with your healthcare provider, because we know there can be some risks, but for some people it can be a very safe option, and it is a way of really managing the symptoms if the symptoms are severe and these other strategies that you're trying are not working. Okay, I'm going to wrap up with sort of general tips for maintaining your health, but really specifically for talking with your healthcare provider. It's can be intimidating. I think we all have been in that, exam room or in a gown where you don't feel comfortable asking questions, or you just want to go with what your doctor says. But I can say, as the doctor, we like it when people ask questions. It's really, we know that we have an engaged patient, a partner in this person's health. And so if you have concerns about any of these topics, I encourage you to talk to your provider, about, do you need any specific testing? Do you, whether that's based on your phase of life or the symptoms that you're experiencing. If the doctor is saying, okay, time to have this, time to have that, you can ask, what is this for? Why should I have a mammogram? Or why am I, getting this pelvic exam? Is this really necessary? And for a lot of people, the discomfort of the exam is a real concern. We do our best to limit that discomfort, but we know that everybody is different. And if you are concerned or hesitant for an exam, be that a breast exam, a pelvic exam, or anything else, you are in charge. And I really encourage you to voice that concern. And if needed, to say no thanks. And to, you can come back at another time, you can find another provider. And if you are expressing those concerns, or you're saying no thanks, or you're asking questions and you don't feel like they're being answered, you do have the right to end that relationship, ask for a different provider, go elsewhere, or at least to express, you may say, this is not so bad that I need to leave this clinic or this provider, but I do want someone to know what happened. So seek out, patient experience surveys, or fill out a complaint form, or ask to speak to someone in management in the clinic. These are all your rights as a patient. Here's some resources. Bedsider.org is great for sexual health and wellness, including talking about pregnancy prevention, and abortion. Show Your Love campaign is wonderful for pre-pregnancy health and general women's preventive care. And then for the specific cancers that we talked about, you can look up National Cancer Institute, and they have specific pages on breast and cervical cancer. So not doing too bad on time, 6:44, and I will turn to the questions. Lilia, do you want me to go ahead and just view them and answer, or do you want to read them out?
I can read the questions.
Okay.
Yeah, so we can, get them answered. So we can start with those perimenopause symptoms mimic any of the cervical cancer symptoms?
That's a really good question. The main symptom, if you're going to have one, of cervical cancer would be abnormal bleeding. Of course, if you have pelvic pain, that's also worth checking out. And I would say yes to that question, because during perimenopause, your periods may change. So if you were someone that was used to a very predictable once every 30 days or once every 32 days or 29 days, or, fairly predictable, and suddenly you start seeing spotting in between, or you go, a month, and then the next month you only go 2 weeks, and then the next month it seems like it's 6 weeks. Those can be signs of perimenopause, and it can be normal. But because of that possibility that abnormal bleeding can be a sign of cervical cancer, it's certainly worth a conversation. If your cervical cancer screening tests are up to date, you may not necessarily need to repeat it at that time, but they can be hard. Those symptoms can be similar. So I think it's worth raising with your provider.
That was a very good question. Thank you for whoever was asking there. Thank you so much. We appreciate your questions. And if you have more, please keep typing in them. We're going to be answering them. I'm just going to be reading as they came first. So the next question is, does breast density play a role in cancer probability?
I'm going to give you my best understanding of that, which is that no, it doesn't play a role in cancer probability, but what it does play a role in is how effective the mammogram is at picking up that cancer. So people who have more density to their breasts, which is normal, there's a whole range of density that can be normal, but it can make the mammogram less effective. It just basically makes abnormalities harder to see. And so if your doctor, or possibly even just on a mammogram report, you see that you have dense breasts, they may recommend additional screening tests like an ultrasound or an MRI, or more frequent mammograms to essentially just make up for the fact that initial mammogram wasn't quite as highly sensitive, I'll say, in the setting of dense breasts.
Well, thank you. I just realized I needed my glasses. I saw was Delcy asking that question. So sorry about the previous one, but now Delia Sotelo is asking, please provide more information on testing of genome.
That's a great question. Yeah. So when it comes to cancer, there are a lot of cancers that can run in families that are hereditary cancers. And if you have reason to believe, based on your family, that cancer does run in the family, then you can have a genetic test that usually tests for a whole panel of different genetic mutations that would say you may be at higher risk for this or this. It's not a helpful test for everybody to have, because we don't really know how to interpret it if it's just done at the population level. And what I mean by that is there are sometimes people do genome testing, for example, through companies like 23andMe or Ancestry, and they're learning things about their family history that they may not have known. But as a health test, it's not something that I recommend universally for everybody, but rather what I do is take a family history. So ask about siblings, children, parents, grandparents, aunts, uncles, cousins. And if there is a strong enough family history, then I would refer someone for genetic testing.
Awesome. Thank you, Dr. Stolberg. Well, Delcy Sanders is asking, can you explain the type or types of fibrocystic findings in a breast diagnostic test, which may lead to an ultrasound of the breast?
Yeah, great question again. And I'm not sure I can explain the types of fibrocystic finding, but I can explain what fibrocystic finding means and why it matters. So fibrocystic changes are benign, meaning they are not cancer. And the sort of common way of describing it is you may notice your breasts are lumpy. It's just essentially a different texture, just like everybody's skin texture can be different, everybody's hair texture can be different, your breast texture can be different. And again, the reason it's relevant is that people who have lumpy breasts, fibrocystic findings, it can be harder to notice on yourself when you're looking or feeling your own breasts. It may be harder to notice a change like a lump. At the same time, the fibrocystic changes themselves are not cancer. So it makes the self-breast exam a little bit harder. And when you go in for a mammogram, they may say, oh, here's a little finding that we're not sure if it's just fibrocystic changes or is it something concerning for cancer. And so they may have you do follow-up tests. Could be an ultrasound, it could be a second mammogram, or sometimes even a biopsy.
Wow, very interesting. I just learned something. Oh my God, that's awesome. Okay, well, thank you, Delcy. Keep coming those questions there. Amazing. She's asking, is HPV more aggressive or difficult for the immune system to overcome in older women, like older than 40?
I'm honestly not sure specifically about age cutoffs, but you are right that the immune system can fight off the HPV virus. And I mentioned before that there's no treatment or cure for it, but it is possible that your immune system can essentially suppress it such that we would never be able to detect it again. And there are lots of factors that can contribute to your immune system being a little bit less effective. Chronic diseases, age, I believe, is one of them, but it's not the only one. So I don't think it's a perfect correlation with age, but I do think you're onto something, Delcy, that things that can affect your immune system may make it harder to fight off that HPV and therefore make the HPV more likely to go on to cause cancer.
Awesome, thank you. And the next question is, what prenatal vitamins do you recommend? Is it better to use over-the-counter prenatals, or are prescription prenatals better?
Okay, great question. And the medical recommendation that I feel very solid giving is that you should look at the amount of folic acid. And it will come in either, it'll usually say it in micrograms. And you really should, if you're thinking about getting pregnant or if you are pregnant, really be getting 800 micrograms or more. You may see 1 milligram, which is 1,000 micrograms. So that's enough. But most prenatal vitamins will have 800 micrograms of folic acid. And that is the one thing that we can say for sure, really all women of reproductive age should be taking 800 micrograms of folic acid every day, just because there's no harm and it can be beneficial. You may have a particular history if you've had a baby in the past with spina bifida or another one of the conditions that can be associated with folic acid deficiency. Your doctor may actually have you take a little bit more. So that's an individual situation. But as the broad population level, 800 micrograms of folic acid. Now, there are other things in that prenatal vitamin that can make a difference. One is iron. And we do know that so if you're iron deficient, it can cause anemia. And going into pregnancy anemic can cause problems later in the pregnancy. And so the prenatal vitamins also have a little bit of iron. Some people notice that the iron upsets their stomach. And so you may notice a variation in the amount of iron. I can't give a specific amount, but there are prenatal vitamins labeled low iron or no iron. And if you are someone who does not have a history of anemia and the iron in the vitamins bothers your stomach, you could look for a low iron or no iron version. All the other vitamins in a prenatal vitamin are the same that you would get in a general adult multivitamin, and they may be reasons that they would be good for you. In the Chicago area, a lot of us are vitamin D deficient, and so there's vitamin D in there, there's vitamin C in there. But really the ones specific to pregnancy or the pre-pregnancy period are the folic acid and the iron. The last thing I'll say about the difference there really is no difference between prescription and over-the-counter. So that's an easy one. If there's an over-the-counter one that works for you, go for it. If you get a prescription and that causes, you have insurance that pays for prescriptions, that may be a reason to get a prescription. But other than that, really whichever one works for you, as long as it has that 800 micrograms of folic acid and iron if you need it. They do make them, gummy or chewable or different formulations of them. And, or if you are vegan or gluten-free, you could look for those other. So those are some of the differences, but those are really just personal preference issues. There's nothing medically different between a gummy prenatal and a chewable prenatal and one that you swallow. Those are just how you prefer to experience your prenatal vitamin.
Thank you, Dr. Deborah Stolberg, for being here. And then we loved you. That was great information. So I'm going to pass it on to Priyanka. So she's going to give us some more information about next week's sessions at SWAP. And thank you.
Thank you, Dr. Stolberg. That was amazing. I just want to share with everyone that next week will be our last week of the Winter Health Series. We are having Dr. Ronald Rembert from Healthy Southwest presenting on men's health. He'll be presenting next Tuesday, as per usual, 6 to 7 p.m. in English and 7 to 8 p.m. in Spanish. I just wanted to note that the links are the same across all the sessions, so you can log in using the same link. We did get through all the questions, but if you do find that you have any further questions, feel free, email me. My email's at the bottom of the screen. It's pready@swapchicago.org, and I'll be happy to pass along the questions to Dr. Stolberg. Additionally, I just wanted to share with you that the organization that I work for, the Southwest Organizing Project, we have a number of wraparound resources. So if you are looking for something, including healthcare, such as Medicaid, it was recently expanded to 42 plus in certain populations in Illinois. So if you're looking for healthcare, if you're looking for food benefits, food, clothing, material needs, behavioral health, or even, basic job opportunities or a city key ID, help with immigration, vaccination, and even neighborhood issues like violence prevention. We work on all of the above with our partner organizations. So feel free to use the QR code on the right or the link I'll be putting into the chat. And one of our public health ambassadors, so our community health workers, will get back to you in the next couple of days. So thank you so much for joining us. We are going to just pause for a second, and then we will be back online in just a couple of minutes with our Spanish session with Dr. Oyola. So if you're here for the Spanish session, just wait a couple of minutes and we will get started. Thank you so much. Thank you, Lilia, for hosting, and thank you again, Dr. Stolberg, for being a part of our session.
Thank you, Doctor.